Thankful to Professor Ramesh Dhulamani for inviting me. So I'll be presenting on surgeries for migraine, particularly peripheral neurectomies. We have vast experience on that. We all know that migraine is a global disease, and many of these patients are drug refractory. You require some interventions for these. There are two theories. First is vasodilation theory, we all know, and second is trigeminal-cervical theory, which says that there are peripheral triggers in the scalp which releases neuropeptides in and around the dura mater, and that causes the central sensitization. So central sensitization because of peripheral triggers. This is the summary of this theory, and it has been supported by many electron microscopic studies. And also we know that many of the drugs have come, like AC inhibitors, which are given for migraine. Botox is given for migraine. These all acts on the trigeminal cervical theory. And we all know that both direct and indirect costs have to be borne by the patient whenever they are suffering from chronic migraines. So the definition of migraine has been defined by the ICSD-3 criteria. I will not go into the detail. We only do intervention for chronic migraineurs. That means whenever a patient has migraine headache for 15 or more days per month, more than 3 months, and for at least 8 days per month. However, we can do surgery even for patients who are not fitting exactly into this criteria. For example, a patient if is having 2 or 3 episodes per month, but still having very severe causing disability to his life, then we can go for surgery. There are abortive therapies, which includes medical therapies, NSAIDs, triptans, lasmiditan, etc. There are prophylactic therapies, and then when these medical therapies do not work, we apply Botox injections or blocks, and if they are effective, we advise them to go for surgery. The options of surgery include neurolysis, neurectomies, RF pulse, and neuromodulation. Definitely the neuromodulation has a implication of high cost, and it may not be suitable for many of the Indian patients, and for these neurectomies or neurolysis are very effective. The problem with RF pulse in my scenario was that RF during the impulse, as these patients are generally done under awake conditions, that short period has it was very painful for the patients. And many of the time the nerves are having a varied anatomy. So in my series I do neurectomies only, and we have shown our results in the randomized control trial. So this is our flow chart. The patient comes, we take appropriate history, we ask her or him from where the pain starts. Now initially the patient will not tell from where the pain starts in the first go. You have to repeatedly ask him. And then you palpate the scalp for his tender points, palpable pulses and scar marks. You have to exclude other causes, for example, refractive errors, pneumolar headaches, and osteomas. So you have to exclude them, even patients who have hypertrophic turbinates. So they are the patients who are not candidates for this type of surgery. Then you apply a block. If the patient is having pain in your OPD, you apply a bupivacaine block. If not, you apply a Botox injection. Do not tell the patient what is the duration of the effect of the drug, and when the patient is having good efficacy of the block, then you go for surgery, either neurectomy or neurolysis. If there is no benefit for the block, you search for other causes and continue medical management. Approximately 50% of patients fit, they can be selected for the surgery. So there are different indices to rate the patient: migraine log, visual analog scale, PSEQ. I will not go into the details of these indices, but these are very helpful to compare the baseline versus the follow-ups. So briefly about innervation of scalp. The frontal headaches are because of supratrochlear and supraorbital. Temporal headaches are because of zygomaticotemporal nerve. This nerve supplies the hairless area of the temporal region. The hair-bearing area is supplied by the auriculotemporal nerve, which is just alongside the superficial temporal artery. The back area is supplied by the lesser occipital nerve, and the midline areas are supplied by the greater occipital nerves. The frontal headache is because of these three muscles. Actually, this surgery, it was devised by one plastic surgeon who was doing eyebrow surgeries for females, and after the eyebrow surgery, the pain got resolved. So you need not to remember very much about these muscles. You need to know the anatomy of the SON and STN. The SON can be in these different types, and you need to be aware of these anatomical variations. The supratrochlear nerve also has is under the muscle, so it is not superficial; it is under the muscle. This is one short surgical video. So the incision is very small for both of the nerves, 0.5 centimeter, 1.5 centimeter. These are the anatomy from the midline, and you need to go underneath the muscle. And this is important for localizing nerve also, and it's also important to bury the nerve beneath the muscle. This is thus you avoid the neuroma formation and the deafferentation pain. And regarding the deafferentation pain, we all know that if you bury the nerve, the cut end of the nerve inside the muscle, and we often, many a times we do large craniotomies, large scalp incisions, and many of the times these nerves get spontaneously cut during the surgery, mistakenly cut during surgery, and hardly these nerves produce deafferentation pain in the postoperative phase. So the surgery is easy. Only thing is you have to little bit pull the nerve and cut it. You can also apply incisions in the hair areas and go endoscopically and do proper neurolysis or neurectomies. The temporal migraine, as I said, the hairless areas from the zygomatical temporal nerve. This is the landmark of this is 16 mm lateral to the lateral canthus and 6 mm above it. The nerve arises from the temporalis muscle and it travels below the superficial temporal, below the deep temporal fascia. So the one important thing is notice to avoid injury of the facial nerve, which is between the superficial and deep temporal fascia. So this is an example of auriculotemporal neurectomy, which travels along the superficial temporal artery. So you can palpate. All these surgeries are done under local anesthesia, so you can reproduce the pain during your surgery. So there was a clear-cut neurovascular conflict. This was easily coagulated and cut. Then the zygomatical temporal neurectomy can be done endoscopically because the pain site is at the hairless area. So you do not want to make an incision over there. You apply incision on the in the hair bearing area and then go beneath the deep temporal fascia. So you again palpate it and reproduce the pain, and then you can cut after coagulation. The surgeries are very simple. The greater occipital nerves, they are around 1.52 centimeter from the midline, and these are beneath the trapezius fascia. So this is important to remember. If you search above the trapezius fascia, you will not find the nerve. And again, you can do either a neurolysis or neurectomy depending on the choice. We do neurectomies and we have good follow-up now. Lesser occipital nerves, you can find them 1/3 distance from the mastoid process to the external occipital protuberance, and these are very notorious. This lesser occipital nerve are notorious for being in variation in anatomy. So you need to properly see them. You need to find and see them, cut them. So this was a study when we compared the medical management versus surgery. So this was VAS score. So this red line is the medical arm and this is surgical arm. You can see considerable reduction in surgery. The second is the migraine headache index. The third is Midas index. We can see good improvement in the disability in the surgical arm compared to the red line of medical arm, and similarly improvement in the pain self-efficacy questionnaire. These results were at 6 months. And these are the preoperative status of all the 4 things, and you can see in the surgical arm again there was good improvement in the Midas, PACQ and MHI. Patients, however, still may require SOS use of analgesics. However, they all become free from the prophylactic propranolol and other treatments. There can be numbness over the scalp. However, it is more when you do proper examination rather than patient complaining of that. The results are durable. At 5 years follow-up, patients have 29% patients, they become completely migraine-free. The improvement is sustained in 88% of patients. So there is immediate improvement that reduces spontaneously in over the some months, but still at the 5 years there is good degree of improvement. This was a multicentric study in 2023 which compared this peripheral neurectomies versus targeted Botox injections. And they found that there was lower pain intensity and work-related disabilities in the surgical group compared to the Botox. Also about socioeconomical analysis, the surgical treatment of migraine trigger sites is a very cost-effective modality even compared to the medical treatment. So to summarize, this peripheral neurectomies for migraine is an option, and these have high chances of success in appropriately selected patients. Of course, you need to also have proper burying of the nerve inside the muscle or below the fascia. There are hardly any major complications, and this surgery is underutilized. I mean, there are many patients in our society which can be benefited from this surgery. Thankful to my teachers.
Thank you, sir. It's wonderful talk. The session is open for questions.
So this has recently been come. So for abortive therapies, we generally rely on naproxen and other sumatriptans and other things. Yes, we can give lasmiditan for abortive therapies. You're right, sir. But again, that's also a very costly tablet. That's 50 rupees per tablet, and many patients require twice a day. And suppose they require for considerable years of time, that becomes very costly for the patients. No, not that.
Right. Thank you. Very interesting. Any prognostic factors to say who will respond to surgery and who won't?
Yeah, biggest prognostic factor is if a patient is neuropsychologically fine and he's responding to the blocks. So if he's responding to the blocks, he will respond to the neurectomies. Yes.
Are you doing one or two neurectomies or multiple neurectomies also? And how much is the sensory loss?
Yeah, mostly patients require one or two neurectomies. We did 3 neurectomies in a single patient, in only one patient. Patient doesn't complain of numbness per se. However, if we examine, then yes, they will complain. Otherwise, patient they are happy with the gone of pain.
What's your recurrence rate?
Sir, in our follow-up of 5 years, yes, patients have started SOS use of analgesis again, but prophylactic they have all stopped.
So any dysesthetic components?
No. I'm surprised actually. There is no dysesthetic complaints in our patients, and many of the patients we know that we do craniotomies. We have some. I think the scalp has some different property than the other body structures. We do scalp incisions, but hardly any patient come with the dysesthetic pain, even in very long follow-ups. Yes, sir.
Those patients which we give scalping, they don't have this migraine. Patients with migraine have a complicated, there are 2 subgroups.
Yes, sir. That's what's in the initial slides I said, sir. Only 50% of patients we selected for the surgery based on the rigid criteria, sir. Not all patients are suitable for this.
So again, just to understand, so you think there's a neurovascular conflict between the vessel and the artery, and if you coagulate or cut the artery and prevent it, wouldn't that be also?
Scalp has a very rich vascular supply, sir. If you
Question is, like trigeminal neuralgia, is there a neurovascular conflict that
yes. In one case there was.
just coagulate the artery?
Yeah, instead of cutting the nerve, coagulate the artery.
Yeah, you are right, sir. You can do that. Actually, you can do that. However, since we are going in and we do not want to have a redo surgery sort of, so we do the whole procedures itself. We do both the things.
technique to localize the site of conflict?
Yeah, you apply a bupivacaine block if the patient is having pain in your OPDs.
Conflict.
Neurovascular conflict, exact location of a neurovascular
No,
conflict.
No, we localize the trigger site. That neurovascular conflict is generally an intraoperative finding.
That cannot be.
Yeah, it cannot be hardly. Yeah, you can do palpation. If it's a surface vessel, then you can palpate it. If it's a deep vessel, you cannot.
The local trigger site always gives you a.
So thank you, sir,
Thank you.
wonderful talk.